12:30. And we're so happy today to have as our guest Lara Palay. And she is the author of the book, The Way Through. This is a great book. It's about trauma responsive care for intellectual and developmental disability professionals. So I'm anxious to dive in and get some questions answered about this for our audience. And so happy to have you here today, Lara.
Thanks, Bruce. It's we were saying before we got rolling, I'm really excited to be a part of this. I always appreciate NAD events, and I'm excited about the Clinical Consultation Network. I think that's such a great it's such a great format for people, and I'm really pleased to be here.
Yeah, we do this every week at 12:30, but the fourth Thursday or fourth Tuesday of the month, we do this NAD feature. And so you're part of our NAD feature this month. So
Yes.
that's an honor for you.
Yeah.
And I will also say that if people come back 5 times, so especially really great authors like yourself come back 5 times, we make you a member of our 5 Timers Club. And that's an honor everyone should aspire to.
I 100% do. That's now my life goal. So thank you, Bruce, for that direction.
Yes.
Get a crown then.
We have a couple of 5 timers. We've done over 150 episodes of this. So
Wow.
we're rocking and rolling.
Yeah.
And so happy to have great guests like yourself. So you're going to be talking to us today about the way through trauma responsive care for intellectual and developmental disability professionals. We've got that coming up. I've got the book right, as a matter of fact. So, and I hope that people will get an opportunity to read this book because it's really great. On August 2nd, we've got Candy Turner coming up. She's an occupational therapist. She's going to talk to us about a falls study. So that's some really great clinical information. We've had a couple of recent choking panels where we've had our seating and positioning staff and our therapeutic staff here talking about choking, but now Candy is going to be our guest next week to talk to us about falls. On August 9th, we've got Rita Pfeiffer, who is a speech and language pathologist who is going to be with us and talk to us about some of her work. Then on August 16th, we're going to have Rita and Kim Lapidus back again to talk about that same topic. So we've got a two-parter there. And then on August 23rd is our next NAD feature, which is Janice Wolf, who has done a ton of work with NAD, particularly was involved in putting together the paper on police interventions, which I am anxious to hear more about as well. So that's coming up next August 23rd on the Clinical Consultation Network. Babs, did you skip a slide? Okay. And so today I have as my co-host Juanita St. Croix. So glad to have Juanita back with us this month. And we have our producer, Babs Tierno, and of course, today's speaker, Lara Palay. So from there, we're going to launch into today's Get Smarticle. We've got Maxwell Smart up here getting the news, and Juanita St. Croix is going to tell us about today's Get Smarticle.
Hello, everyone. I love this feature, the Get Smarticle. It just plays to every sense of humor that I have in the title. So we asked Lara to share with us an article about trauma that has helped inform her practice, and it is certainly part of her publications, or informed her publications. So the article that we're talking about right now is a systematic review of treatment interventions for people with intellectual disability and trauma symptoms. A review of recent literature by Gary Byrne. And we have the citation there for you if you would like to take a look at that. So the goal for the article was to take a look at the various types of therapeutic interventions for PTSD, so post-traumatic stress disorder and its associated symptoms. And the two that the article focused on were cognitive behavioral therapy, CBT, and eye movement desensitization and reprocessing. So that's EMDR. Both of them are utilized fairly widely for people who have intellectual and developmental disabilities, all along the spectrum, so mild, moderate, severe, profound categories of delay. And then the article has looked at literature that evaluated their effectiveness. So a little bit about post-traumatic stress disorder and IDD. Post-traumatic stress disorder and trauma-related disorders are conditions that people who have been diagnosed with IDD are thought to be more susceptible to developing due to the increased likelihood of experiencing adverse and traumatic life events. And that's from Wigham and Emerson. We also know that people with intellectual and developmental disabilities may have less ability to process experiences that they have to help prevent PTSD from really entrenching. So what the literature says, CBT is a largely goal-directed and problem-focused therapy. Over the past 20 years or so, CBT has been determined to be effective with people who have a mild to moderate IDD. They tend to be somewhat less effective for people who have severe to profound intellectual or developmental disability, largely due to the interactive nature and the requirement of self-reporting at times. When we're looking at EMDR, this is the one I'm going to have to read straight on because I never remember this. Even the words, the acronym for the EMDR, it's a tough one for me. So EMDR is 8 phases. The process is 8 phases that emphasize the role of memory and information processing symptoms in the treatment of the psychopathology related to traumatic incidents. There are 3 elements involved. That's stabilization and developing a sense of self-mastery, processing memories and triggers, and then teaching appropriate skills for social interactions. When we compare the two, evidence from trials of CPT and EMDR interventions from 2010 to 2020, they were conducted on both adults and children who have IDD. So they were looking at the literature relating to treatment for children and adults. And the conclusion of the review is that there are real barriers in completing research around the work with people who have intellectual delay. I'm learning Spanish. That's the Spanish word for that.
Oh.
It is not. I'm sorry. That is not the Spanish word. That's a massive typo.
Totally would have believed you. I was like, I learned something new.
Credible. I lie credibly, so it's good. And it was. It's critical that treatment approaches are measured for effectiveness, and I think we all know that research and measures of effectiveness are critical, but there are some barriers to getting really effective numbers and really effective studies done on treatments. So more comparison, the present review provides tentative evidence for the potential of EMDR and CBT, but I think the actual practical evidence is out there. It's just getting it on paper, essentially, that the research backs that up, the experience of others. Before making a strong recommendation, the gaps in literature that were found, the lack of routine outcome measures, poor methodological rigor of studies, and small sample sizes. So we need to look at some of those things before we can really rely on the literature to back up the experience that people are having. Appropriate standardized treatment measures are required for not only helping develop, but also guide appropriate treatment protocols. So that's the essence of the article, which brings us along to Lara's book, The Way Through Trauma Responsive Care for Intellectual and Developmental Disability Professionals. So this book is intended to provide information and resources for professionals working with people who have an IDD to be able to effectively recognize the signs that someone may have experienced trauma and help to contribute to the healing of trauma for people they support. So Lara is going to do an overview of her work here and talk about, honestly, whatever the heck she likes to, because we're going to learn whatever it is that Lara has to talk about. But I do have a very brief introduction in getting to know Lara, and she has been prepared to share something with us that people may not know about her.
I'm ready. Yes.
Good. So this is just a straightforward introduction directly off the cover of Lara's book. I have had the pleasure of introducing Lara, I think now at least on 3 occasions when she has spoken, and I can guarantee you I could read a book on her accomplishments and her appointments over even just the past 10 years. So Lara is a psychotherapist with 25 years in practice, specializing in trauma and loss. She's a co-founder of Aldrich Palay Consulting. And Ms. Palay started her career as an hourly worker in the mental health field and went on to supervisor and clinical director for multiple mental health agencies. In addition to clinical practice, she has taught social work graduate students for more than a decade. Ms. Palay served as the project manager for the Mental Illness and Developmental Disabilities Coordinating Center for the state of Ohio. So I won't keep you any longer. I am so delighted and honored to introduce to you Lara Palay, who's now going to share something that people may not know about her.
Okay, so I thought about this a lot, and I had so many things to choose from. But the thing I felt I wanted you guys to know about me is that, and Juanita, you're going to have to help me a little bit with this. You can't necessarily tell from the computer screen, but I am, as I like to call it, a petite American. I am less than 5 feet tall, or as my son once described to one of his teachers, 4 foot scary. So I'm a very little person. And one of my jobs when I was in college was being a bouncer at a bar. And I was actually pretty good at it, I'm going to say, because you don't win a lot of points with your crowd of friends or the girl you're trying to impress if start a fight with a woman who's less than 5 feet tall. So I would just like tug on people's sleeves and say, "You have to leave now," and they would leave. So that's a fun fact about me is that I was a bouncer at a
That's a
bar.
great fact. What was the name of the bar?
It was called Bernie's Bagels and Deli, but they had like on one side it was sort of a deli, and this is at the Ohio State University, and on the other side there was this bar. Now, to be fair, it attracted a little bit of a smaller crowd than like the big meat market bars, but I
Yeah,
do think every bar should employ this. You look like a
I,
jerk
I
if you
agree.
touch me,
Brilliant.
right? Like
Yeah.
you do not look
Yeah,
cool.
it might be actually much more effective than the
This is what I'm
approach
saying.
that
Now,
I've seen taken before in that is a
exactly.
very interesting fact. It's
It
also
is. Thank
yeah,
you.
yeah.
Yes. Now, I
That
did go on
is.
to,
You're
I, I went on to teach self-defense for 15 years after that. So I would have been pretty effective at bouncing people, but fortunately,
Mhm.
I never had to.
that's
Um,
great.
yeah. So that's the fact
You're the
about
Spud
me.
Webb or Muggsy Bogues of bouncing.
Yes. Yes, I am. So,
Those are basketball players who were kind of diminutive.
yeah, exactly. So that's the thing about me. And I think maybe what I can do is just launch into why I wrote the book and sort of what my perspective is in terms of trauma and dual diagnosis. And I'll weave in a little bit about why I chose the article that I chose today for us to talk about as well. So, as it mentioned in my introduction, I'm a mental health person. I'm not a DD person. And I started at one of my many college jobs working at a crisis center for teenagers. I write about this a little bit in my book and fell in love with it in a number of ways, much like I think a lot of people in DD started out doing hourly work and kind of fell in love with it. And that's how it became their career. So I just felt a lot of kinship for that. And because I got an opportunity to later be a supervisor, I felt like I had a sense on both sides of that coin, right? What it's like to be the person who's got a number of people and a lot of responsibilities and sometimes not a lot of time, sometimes not a lot of power. Sometimes training is wonderful, sometimes it's not so wonderful, and you've got to get people through their day or help people reach goals. And I'm also very sensitive to the role of managers and what it means to try to support staff and lead staff. And when you have never enough time and never enough resources, how do you make information useful and usable? So that was sort of my professional experience that kind of set the stage for that. And then I, in a number of different ways, came into contact with trauma. Actually, partly through my work as a self-defense instructor. It was a course mostly for women, and so much trauma, so many women coming in with traumatic experiences that they were kind of addressing through self-defense, and certainly in my private practice. So my private practice for a long time focused on kids with cancer, which is a very different wheelhouse, but there's a lot of trauma and a lot of grief in that as well. And a little side note, grief is I think kind of the next thing that we'll be looking at in the developmental disabilities field. I know there's There's certainly some attention paid to that, and I think that will soon be taking its place alongside with trauma as these sort of invisible things that people are dealing with. So that's sort of how I came to this work. And then my current business partner was running policy for the state of Ohio and asked me to come on to run a program that they'd been doing for a number of years. And I became sort of a liaison between the Department of Developmental Disabilities and the Department of Mental Health for the state of Ohio. So that's how I first learned about NAD and first got to do some work with NAD, and that was really fun. But what struck me, and what I talk about in the book to some extent, is when I started working with the dual diagnosis folks and the field of developmental disabilities, and this was gosh, about 12 years ago now, I would hear the same diagnoses over and over, right? That people would talk about, well, we've got Juanita, and she's dealing with ADHD, and she's bipolar, and she's schizophrenic, and this and that. And it may sound like I'm exaggerating to make that all one person, but I heard plenty of cases where
Right.
someone would have all of those diagnoses, right? Bruce, I can see you as I'm saying this.
Yes, definitely.
One
You see a
person,
laundry list usually.
right? One person has all of these things. I'm not saying it can't happen, but as a mental health person, I would think, wow. And initially, when I was first exposed to the world of DD and learning about this world, I would think, I'm certainly not an expert. Maybe people really do, if they have a developmental disability, also have 5 different major mental health illnesses. And then what I learned and what I became very passionate about is, no, people with developmental disabilities aren't that different in terms of how their brains work, in terms of all of that stuff. They're just much, much more similar than they are different. And so I believe, and I think people's clinical experience, all the experts I've gotten to talk to in the years since then would agree that people are much more similar than they are different. And it's not terribly likely that someone has 4 major mental illnesses all at the same time. But here's what really got my attention. What got my attention was that I knew, as a mental health person, that trauma is okay, I'm going to totally nerd out here. So I hope you guys are going to come with me on this ride. But for any Harry Potter people, trauma is kind of a boggart, right? Okay, it looks like different things. And so you could have, Anne might be looking pretty depressed, and Asia might look very reactive and volatile. Charlene might be having a lot of rigidity because she's trying to control being triggered. So, right there, it looks like depression, it looks like anxiety, it looks like OCD. When someone is freaking out about something you can't see,
Yeah.
that looks like, the polite term would be schizophrenia. The term we would actually use would be, oh, Lara looks crazy. I have no idea why she's doing what she's doing, right? People who don't have what I consider to be a solid grip on what bipolar actually is would sometimes say that when someone fluctuates in their mood or their presentation, they would look bipolar. That's a story for another day. And my personal
Laura, I was
favorite.
just going to say, I and I've told this story before, but
Yeah.
we learned about a person who was describing herself as having had been raped by a Sasquatch,
Yeah.
and people were attributing this to a psychotic disorder, and
Mhm.
yet that was not what happened at all. This was a very hairy individual who actually raped her, and
Yes.
so this was her trauma.
Yes.
And we confuse this all the time with psychosis.
Yes. And I want to be very clear that the point that I'm sort of taking a long time to make here is that in mental health, we get it wrong all the time. To leave out all of the complications of a developmental disability, or someone who has difficulty communicating, or they communicate in a way that's idiosyncratic and personal to them, and you don't know what they're talking about. Leaving all of that aside, it was kind of an anecdotal thing in mental health for years that the average person diagnosed with PTSD would have had 4 incorrect diagnoses first, on average, by the time someone landed on the right one. Now, I think that things have improved. I don't think that's always necessarily going to be people's experiences now, but it certainly still happens. And so, what struck me as I was starting to learn about these world and meet all these cool people working with people with developmental disabilities is I would hear all of these diagnoses that are the usual suspects for misdiagnosed trauma. ADHD, bipolar. Again, as I was going to say, my personal favorite, borderline personality disorder, which usually means that someone has made a clinician really annoyed at some point.
I was going to ask you about that one specifically. I find that
Yes.
one almost the most one of the most atrocious diagnoses for people who have an IDD
Yes. So,
because they don't get touched for service.
oh no, 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 no. And here, okay, so we're going to take a little side note here, but I'd love to talk about borderline. So I taught the DSM in grad school a couple of times. I'm not very good at teaching it because I don't like it.
Yeah.
I diagnosis is sort of a mess, to be honest with you guys. And I touch on this a little bit in the book, not because I think most people reading the book are going to run around diagnosing people, but because I think it's important to know a couple of things. Number one, there are very useful and helpful diagnoses within the DSM, and there are diagnoses that have always been problematic. And personality disorders is a whole category where there's not a lot of agreement about what that means. There's not a lot of agreement about what a personality is. There's not a lot of agreement about when does someone go from being annoying to having a distorted personality. They're not terribly well conceived diagnoses. Do you know what I mean? Schizophrenia, weirdly, is fairly straightforward, and it presents pretty consistently across cultures. The rate of schizophrenia around the world is pretty consistent, around 1%. Bruce, you're nodding at this. So it probably really is closer to a disease.
But if you go by the number of people with IDD who take antipsychotic medications, it's around 30 or 40%.
Yes.
So,
No, right. So, and that's controversial, right? Okay, so this conversation is just going to be all over the board. There may be a greater susceptibility to whatever the brain situation is with schizophrenia. Schizophrenia may be a single disorder, or a lot of people think it might be multiple brain disorders that kind of get lumped into this experience of schizophrenia, this disruption of the ability to perceive reality correctly. And there's some speculation that someday there may even be blood tests that we can do for this. So there is a strong there's strong reasons to believe that schizophrenia has a biological component to it. And it may be that people with developmental disabilities, along with whatever insults to the brain they've experienced, may be more vulnerable to whatever schizophrenia is. However, it's also
40 times as likely, though?
Oh, exactly.
Yeah.
The research is not there for me to be able to answer that. But
Yeah.
Bruce, I feel like we're saying the same thing, which is no, I don't think that's likely. What I think is likely is that I'm just going to be honest with you guys. I think we chemically restrain people sometimes. I don't think that's what we necessarily intend to do. I don't think that's what we tell ourselves we're doing. But when people can't figure out what's going on with somebody, meds are typically the first thing that they think of. And if you give people enough antipsychotics, I'm just going to be really blunt. They become a lot easier to deal with, don't they?
Yeah,
So
I think medications also really, really calm down care providers and caregivers.
yes, they do. And again, I
Sometimes
think
they become easier to deal with. Sometimes the side effects of those medications also cause a lot of problems
yes.
as well.
And I think there are a number of issues going on here. Number one, the reason I wanted to start with sort of my street cred about doing hourly work is that I did work at different phases of my career with very emotionally disturbed teenagers who had real challenges in terms of being around another human being, people who could be dangerous, people who could be very sexually reactive. I never want to make it sound like I think people are running around just medicating people for no reason, or that they're a bunch of, black hats running around. But I do think we go to medication before we think about psychotherapy, which is part of why I wanted to use that article today, because we are starting to get better research and more literature about how to do real psychotherapy with people with developmental disabilities. But I think a challenge that we still face in dual diagnosis is meds are too often the first and last thing people think of. And I have a joke in my book that I tell with audiences. My dad is a pharmacist, so I love drugs. Drugs are great, right? Drugs for everybody. My issue is not with medication. My issue is that sometimes we do it because we can't think of anything else, or because a family member is bugging us, or I've talked with nurses and doctors who say, look, sometimes we get a supervisor or staff who say, they're doing this, 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 you need to fix it. We think they need more meds, and they kind of go along with it. And the other problem, Bruce, is something that you were talking about a few minutes ago, which is my experience is that sometimes medical professionals, especially if they are not familiar with and comfortable with working with people with developmental disabilities, if they are not specialists who feel confident, they're reluctant to take anything away. They're ready to add something. And so I've seen laundry lists of diagnoses and meds beyond which I would imagine any one human being needed, because they're ready to try to add a med. Oh, are there side effects we don't like? Let me add a med for that. And people are more reluctant to take away. So we sometimes, I think the meds are lifesavers, but sometimes we get people who are incredibly medicated. And then they're like, oh, well, Bruce is nonverbal. Yeah, no kidding. I would be too, So yeah, Bruce, I think you're ready to jump
Now
in.
people are probably trying to get me prescribed some medication to achieve that outcome. But
Right.
it's a big part of how our system operates, and we're always looking for an immediate solution to everything. And I think that contributes to that quite a bit. It contributes not only to that, but to other restrictive types of things that we do with people that often are not very helpful and really distract us from the primary issue of concern, which, as you brought out, is trauma.
Yes, and I think that's such a beautiful segue. It's going to seem like we set it up, but that's what the title of my book is talking about, that it is very challenging to work with folks when they are reacting to something in a really big way, or when they are shut down. It is very, very challenging when we don't know why, which is often the case. And I will say that is often true with people who are neurotypical. They don't know why they're triggered by something; they just are. But it's frustrating. It's challenging. And what I learned as a staff person, and then learned in a different way as a supervisor, is it, as challenging and time consuming as it is worth taking the way through, rather than jumping to, how do I get Bruce to stop doing this annoying or frustrating or dangerous thing? Like, I get it. Sometimes we've got to figure out how we can stop Juanita from running into traffic or harming herself or harming someone else. This is not easy. But I think I make the case in the book that when we take time to figure out what helps someone to feel safe, to feel connected to another human being, to feel in control of themselves, it is longer than medication.
Yeah.
I can zonk you out on meds in half an hour.
Yeah.
It is longer than a behavior plan. And again, I think meds and behavior supports are wonderful tools, but bad. There's a saying, right? It's a good servant and a bad master. It is not the be all end all. And taking the way through works much better in the long run for two reasons. Number one, you're less likely to, be using a hammer as a fly swatter. It's much more targeted to the person when you figure out what they actually need. But the other thing is that we don't have the risk of over medicating people, chemically restraining people, too many. I'll talk about behavior stuff for a second. I think a well-designed, sensitively applied behavior plan can be wonderful. But honestly, sometimes that's not how they get written. That's not how they get used. And I think sometimes staff are punishing and isolating people and shaming them in the name of using a behavior plan. I am going to ignore Bruce's behavior. I talk about this in the book. I'm not sure I know how to ignore behavior without ignoring a person. And I think that happens a lot. So again, I think coming from that mental health perspective, it was natural for me to be much more holistic about it. Yes, a behavior plan can be super helpful. Yeah, the right medication to support the anxiety or the depression or the panic or the nightmares or whatever. Great. But that's not the center of it. That's not the
Well,
heart.
and you find that once you understand the source of, the concerns that someone has, actually, I almost think it's easier once you understand where it's coming from
Oh, 100%.
versus attributing to all these really bad things. Because what it seems like you do is continue trying to solve the same problem over and over and over again with these really sort of draconian approaches to things versus
Yes.
basically trying to understand what's going on with the person.
Yes, 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 yes. And the problem you are trying to solve, and again, I feel this frustration, but it very quickly stops being the problem with Juanita and becomes Juanita is the problem. And in fact, I often will start if I'm talking to an audience, I'll start by saying I'm going to disappoint you guys because I think you might think that I'm going to come up here and tell you how to fix Juanita. And the trick is we're not going to fix Juanita because Juanita is not the problem. Juanita is to talk in terms of trauma when she becomes dysregulated, if she gets triggered into in the book, I kind of go through and lots of different ways of thinking about hyperarousal, which is that fight, flight, also freeze and fawn, which you may be less familiar with, but that adrenalized thing. Or if she goes in the opposite direction and becomes shut down and disconnected and numb, either way, those are survival protocols. She is supposed to have those in her brain. I have those. Amanda has those. Bruce has those. Anne has those. Carrie has those. We all, every animal, even, well, even down to like a little amoeba, but certainly in mammals and primates, we have that same repertoire of, I got to get out of here, or I'm going to check out from this because I don't like what's happening and I can't get away. Either way, that's how our brains are built.
So
And so,
rather than behaving in an aberrant way, they're really behaving as naturally as you would expect a person to respond.
yes, yes. And for me, behavior, oh, I have a love-hate relationship with that too. Because understanding behavior can be very effective, but the very word behavior from a mental health perspective implies a conscious decision. I have decided to lift my can of water and drink from it. When I am lashing out in fear, or when I am shut down into a almost a fugue state because I'm in my survival protocol, I'm triggered into a trauma, from my trauma. That is fast, much faster than I can think, much faster, maybe half a second, which sounds really fast, but in brain terms, that's very slow. So one of those things is like a bullet train from Tokyo, and one of them is, your grandma's Oldsmobile. That's how different they are. But when you say that I'm having behavior, what you are implying is that I'm choosing what I'm doing. I'm choosing to be dangerous. I'm choosing to upset you. I'm choosing to disrupt the day. I'm choosing to freak everybody out. And that is not what's happening. I may make those choices at other times, for sure, right? But in those moments when I'm triggered, it is much neurologically closer to me having a seizure. And if I fell on the floor right now and started seizing, none of you would be thinking, oh, what a strange thing she's decided to do right now. What an odd choice. You'd be very clear that it was something happening to me, not something I was doing to you.
I-
So to
I
get back
just-
to yeah, go ahead.
Sorry, I just love the way you explain this. To me, it is the heart of person-centered thinking and person-centered supports, approaches, just a person-centered world. That you're person first, as
Yes.
opposed to something they're doing or something they're choosing. Everything is behavior that we do. Blinking my eyes is behavior. Am I thinking about it? No, I'm not. But as a human being, I blink. As a
Mhm.
human
Well,
being, I
what I was
respond.
going to bring up, a lot of gets surrounding this word behavior.
Yeah.
But, I think part of the problem is that a lot of times we're looking at the large behavior, like, okay, physical aggression, property destruction, other things like this, where you really need to be looking at like the small ball. What we call it in baseball, we call it small ball. When you bunt a runner over,
I'm
it's
learning so much about sports in this
Yeah.
one session.
Yeah, I'm doing too much sports because there's too many people probably who don't like sports out here. But nonetheless, it's getting down to the details. And so, as an example, I had one person I worked with who you could look at her facial expression, and you would see. Like you would be having a conversation, maybe she's asking you for a favor or something, and then you start in with, well, and immediately that word triggers
Yes.
a complete change of facial expression because she is so sensitive to the fact that I'm about to say, no, I'm not going to do that favor for you, that
Right.
she's already reacting to it. And this was, I believe, was a trauma reaction on this person's part.
Yes, I love that example. And I want to be clear about a couple of things. And one of the things I talk about in the book is that when you say trauma, a lot of times people think of what we call big T trauma. Someone assaulted her, someone molested her, someone, whatever, someone trafficked her. And that absolutely could be the case. Or if you think about little T trauma, what is it? Why would someone react so strongly to not getting something they want? Well, how do you react when you don't get what you want? And now imagine that that happens all day, every day. All day, every day. You, whatever it is you want, however trivial or important it is to you, rests in the hands of someone else. I don't know, Bruce. Have you earned it? You haven't
Look,
had a very good day today. I would freak the F out. I'm just going to be super real with you guys. Whenever people talk about oppositional defiant disorder, I'm like, oh, that's me. I do not care for people saying no to me. And for what it's worth, by the way, that diagnosis is kind of nonsense. But so if you look at her, we tend to think someone abused her, someone assaulted her, someone did that, which absolutely is possible. We know from solid research that people with developmental disabilities are more vulnerable to all of those things. Don't even get me started on sex trafficking, it's a whole thing.
Yeah.
But they're also highly vulnerable to little T traumas that most of us don't experience.
yeah,
The late great wonderful John McGee talked about, he used to say
yeah.
he thought 90% of restraints around the world would go away if people could just have the can of diet pop or cookie or cigarette that they wanted. Now, I understand that in application things are more complex than that, but I think he makes a really good point. When people look for comfort, I'm going to get what I want, I'm going to get my needs met. Imagine what it would be like for us if some other person, usually a team of people, some of whom don't know me very well, some of whom maybe haven't had much training, um, get to decide. Yes, you can. No, you can't. Yes, you can. No, you can't. So that reactivity starts to make more sense in that context. And I will just say one more thing, which is when people have been traumatized by other people, which is usually what we're talking about with people with developmental disabilities, it's usually not they were in a car accident, although it could be. They become, Bessel van der Kolk talks about them becoming human Geiger counters, or human size. They become so perceptive and sensitive to the slightest shift in your voice. So when you talk about that, Bruce, like, just getting to say the word well,
Right.
you're already there. And again, that's a survival strategy. If I grew up with people who were explosive and unpredictable, my ability to read their face and voice and hunker down or get aggressive or whatever I'm going to do, that may have saved my life. So getting back to the larger point of this is not a pathology. It's difficult, it's challenging, it messes their lives up for them in some ways. It can be dangerous. I'm not romanticizing the stuff that people do out of fear, but I will say, when people work with me in my private practice for trauma, we start with these are not symptoms and pathologies. These are survival strategies that your brain has put in place millions of years ago. You don't have control over them. You can recognize them once they've started, right? So Bruce, going back to that lady, if you were working with her and you guys worked on the reaction, a couple of things might happen with a lot of time and practice. One, she would more quickly be able to recognize it, right? Oh, I'm feeling scared. I'm feeling angry. I'm not going to get what I want. You guys might be able to work out some language about that, how to deal with that. And enough safe, predictable interactions with you, some of that sensitivity may diminish a little bit. I feel
Well, actually, that's exactly how it happened with
Yeah.
her, was that she gained confidence over time
Yes.
that this was, well, didn't necessarily mean no, or it might have meant the beginning of a negotiation or a discussion about something. It did
Yes.
not necessarily mean that it was going to turn out negatively for her. And as a
Yes.
result of that, that was very therapeutic for her.
Yes.
In that circumstance. By the way, I want to give you a big shout out for making a NAD reference there with McGee, John McGee, co-author of the book Gentle Teaching with Frank Millicino, and one of our great heroes in NAD lore. And so that's great. I'm going to pause for just a second and see if we have any questions in the chat box or comments. Babs, can you review any questions or comments we might have so far?
We've had a few things that have come in. Um, okay, one of them was, and this was, you were talking earlier, but isn't it because medications are more easily accessible and psychotherapy isn't? And that
Mm,
was, I don't, if you remember when you were talking about the propensity to medicate. Um,
yes.
and then she goes on to say, and this is Margaret Newbury, I think systems are set up so that behavior plans are also more accessible, think funded, than therapy. So we play whack-a-mole with behaviors, get rid of one and another one pops up.
Yes. Yes.
So do you want to respond to that?
Absolutely. Margaret, I am totally on board with you on all of that. I think, and again, to be clear, I, it- mental health and medicine are just like every other profession. There are wonderful, gifted people. There are people who are, there are people who maybe shouldn't do what they do. I work closely with psychiatrists and nurses, and I think that's wonderful. Having said that, there are a couple of gaps that are kind of creating this terrible perfect storm. Number one, things are getting better, and NAD actually has a lot to do with this, I think, as a national presence in terms of exposing more med students, more nursing students, more doctors, more nurses to working with people with developmental disabilities. So I believe this is getting better. However, depending on where you are, and I found this to be true, especially if there are places that are already underserved, maybe rural areas that don't have a lot of resources, it can be hard to find a nurse or a doctor who's comfortable with what they're doing. And meds are easy, right? So I think that's part of it. I think another thing that's part of it, and this is directly on mental health and the mental health system, is we don't have enough resources for anybody, but we certainly don't have enough education about working with developmental disabilities. A story that I tell to my audiences a lot is the truth is that, and I'm not proud to tell you guys this, if you had tried to refer, let's say, a young person with significant developmental disabilities to one of the mental health agencies where I was a clinical director, I would have turned you down. I would have sent you away. Not to be mean, right? But because I would have told you, I don't know how to do that. And my staff don't know how to do that. One of the reasons why I was wanting to write my book was that, and this also goes back to something you talked about, Bruce, a minute ago. Um, people are much more alike than they are different. And so, for example, in that article, they talked about, yeah, there are limitations, let's say, with CBT, working with someone with, moderate to severe developmental disabilities. That's true. I think there are limitations for CBT treating trauma with neurotypical people, but I think EMDR is actually a really promising intervention for that very reason. But the point here is therapists who are good at working with people can be good at working with people with developmental disabilities. Generally speaking, especially if you're talking about mild to moderate needs for support, which is the vast majority of who most of us are going to be working with, uh, you can figure that out, and you can use family and you can use staff and you can get yourself educated, but you can figure out pretty common sense things for how to work with people. And so part of the problem, Margaret, getting back to you, is there aren't enough mental health practitioners who think they can work with people with developmental disabilities. And some of that, I think, is a need for training and advocacy in the mental health world. Some of that, I have seen DD teams and DD providers reach out to the mental health practitioners in their area saying, let us work with you, let us do a little training, let us show you that this is easier than you think it's going to be. So I think there's a huge need for that. Um, and
Laura, you also mentioned that you work with managers and with staff who work with people, right? I mean,
yeah,
so you're trying to get them up to speed on some of these things so that they can be helpful.
yes, and to be effective advocates. And I want to tie that into something that you mentioned earlier. And this really, I think, addresses some of what you're talking about, Margaret, as well. And it is this. Bruce, you said that those interactions with that woman where she essentially learned that you're safe. You're not going to be arbitrary. You're not going to be unpredictable. You're going to try to help her get what she needs and wants. You said that was a very therapeutic experience for her. And I loved it when you said that because you weren't doing psychotherapy. right? I want every individual in every state in the country to have access to skilled psychotherapy, but that's probably not going to happen. Maybe someday, right? But that's okay, because what heals trauma is repetitive experiences of safety and connection over and over and over. And the truth is, being able to go into Bruce's office and say, Bruce, can I have that extra cookie? And we're going to talk about it. Or, who's somebody I haven't picked at Clayton, Clayton, making sure that staff know how to help me feel safe, connected, and in control. And all the behavior stuff and all of that other stuff can come next. Over and over and over is what heals trauma. Therapy can be a really powerful tool, but it's the relationship and the safe experiences that teach my brain and my nervous system over and over and over that I can be safe with the people who are around me. Our brains learn by experience,
Mhm.
which is
And-
part of why I don't love CBT.
Yeah.
But that's a conversation for another day. Our brains are experience dependent organs. All of our brains right now are figuring out if we are safe based on all of our past experience and all of the information in our sensory environment at every given moment. We are usually not aware of this.
Laura,
But
we should go on for hours with all this because
yes,
this is
right.
such a great interview. I mean, I just
Yeah.
loving everything that you're saying. One of the things I wanted to ask about, because in your book, you talk about these calmer skills
yeah.
and how those weave in. So tell us a little more about that.
Yeah. So, and this addresses a question from something in the beginning of the session where it talked about identifying people with trauma. And I want you guys to think about that in two ways simultaneously. Okay. One is if I'm working with Cutter and I'm like, wow, this person, Cutter, I don't know if you're a dude or a lady or whatever, but so Cutter seems to really struggle with feeling safe. Cutter either, kind of explodes and freaks out or shuts down. I think maybe we should suggest that Cutter get an assessment from a trauma informed clinician or maybe a local trauma therapist. I think that's a great idea. But there are going to be people you're going to miss. And so in my book, I talk about safe, connected, and in control as being the opposite of what trauma is. Trauma is when we are made to feel unsafe and out of control. Helping people to feel safe, connected, and in control helps calm the brain down so then they can kind of be back in reality. They can be interacting with us for what's going on here. When I'm sitting in Bruce's office, I'm not actually threatened. So when I can calm my brain down from that trigger, I can interact with Bruce as he actually is, someone who's safe and reliable. You don't need to know the trauma to do that. And I think that's important because you won't always know the trauma. If you kind of think that might be what's going on and you want to get some expert input, I think that's a great idea. But all of us need to feel safe, connected, and in control for our brains to be integrated and for us to be interacting appropriately. So that kind of gets people off the hook of trying to have to figure it out. The second thing is, as I said before, I sometimes disappoint audiences because I'm not going to give you the magic spell for working with Cutter. You guys know Cutter. You guys can work with Cutter. I don't know Cutter. What I can do is help you be the person who can help someone else feel safe, connected, and in control, right? Because as many of you have experienced, many of the folks we work with are brilliant at knowing how you feel. So when you're pissed off, you're shut down, you're frustrated, you're triggered, whatever, they feel it, you know? And when we're busy yelling at someone, you need to calm down, that is rarely calming. That does not calm me down. So the calmer skills, I've been married for a long time too. My husband can tell you, telling me I need to calm down is not going to do what you want. So what does help is when you have a set of tools, and that's what the calmer skills are, that and I always encourage people, make it work for you, choose what works, add your own stuff. That's all great. But it's a mindfulness-based approach of grounding ourselves when we can feel relatively safe, connected, and in control. And the calmer skills are just sort of step by step to go through that. It is easier for me to be able to communicate to Babs or to Juanita, I'm I'm okay in this interaction with you. I'm calm in this interaction with you. You and I are going to figure it out. And I don't need the magic words. Sometimes it's not even what I'm saying. Bruce, going back to that lady, my guess is when she walked in your door, if you didn't go, oh, here we go. Oh, but if you stayed relaxed, you're like, oh, hey, long before anyone needs to say any words. So it's really not about the magical spell or the perfect behavior plan. It really is about when you are that safe person, when you are able to connect to them, they will automatically start to calm down. Now, for some people, I'll just say this last thing. When trauma has happened early in life, when it has been severe, when it has been chronic, and I believe many folks we work with have had all three, that may be a lifetime of undoing those lessons, right? And so on the it will be slow going, and on the bad days that person may go right back to the stuff they did to feel safe before, being aggressive, being shut down, whatever. But that is the way through, and it is based on the relationship. So therapy's great, meds are great, behavior plans are great, but that's not really what drives healing. Okay, I could go on, but I know we have more
You
questions.
could, and actually, I wish you would, but
Yeah.
we're limited on time. But we didn't get to talk about the brain basics, which I think you were alluding to there. Is that if somebody's had severe trauma, a lot of times their brain has been changed in a way that it makes it very difficult to heal.
Yes,
And,
yes.
so it is fascinating though to hear you talk about this. I just wrapped with attention
Me
about
too.
this. Uh,
Thanks,
I
guys.
appreciate you coming on and talking to us about this so much.
Mhm.
And I do hope you will be a subsequent guest for us.
Oh, I've got a date already picked out to ask her for. So, but I did want to comment quickly on something that I heard you say many years ago, Lara. Um, One of the pieces of advice that served me so well in my interactions with human beings, all human beings over the years, is come from a place of believing everyone has experienced trauma and approach people in that manner. And that is one of the most therapeutic things that
Yeah.
I found useful,
One of the
helpful.
things
And
that Marshall Lennon, oh, I'm sorry, I didn't interrupt. Go ahead.
no, I was going to say, I think that those are the magic words.
Yeah.
Like you talk about not having the magic words, but those are the magic words in your interactions. Come from that place where you you are providing this safe approach for people. People know they can approach you, they can talk to you, even when triggered. You're automatically going to create that safety for them while you create safety in your environment and all of those pieces as well that you absolutely have to do. And I did want to say, I love this book that you've written. I just love it, and it's making me rethink a chapter that I'm writing for another book because your style is so accessible. Yes, here's the book. Bruce was holding it up as well. The way through is unbelievably accessible. You will feel like Lara is speaking to you. I'm not just crazy. I swear to God, I'm not just crazy. Like this is
You might
probably
need some
one of the most
antipsychotic
helpful.
medication for that. But
Yeah. Thankfully, I don't have borderline personality disorder because dear are so
Oh, yes.
treated so poorly in our systems. But anyway,
Yes, bring me back so we can talk about borderline. They are incredibly misunderstood and they're my favorites. So
me too.
actually, borderline's not a bad word to me anymore. I used to think of it that way, but now, because of understanding the trauma
Yes.
that underlies that, I really have a whole different view of it.
I have a whole different view too. It's just trying to get people to provide service to people who have
Correct. Yes, that is,
yes.
it's one of those things that makes it really difficult. This
Yeah.
has
Yes,
been
it's
so
like going like,
great.
hey, right. It's
Go
like
ahead.
saying, can I refer Dracula to your program? No, you don't want me
Oh.
to? Yes, yes, I feel you.
Right.
Yeah.
Well, this has been fascinating. Laura, thank you so much for being here with us today. We really
Thank you
Stay
so much,
tuned for an
guys.
announcement of her next.
Yeah. And thank you to all of our audience for being here today and each and every week when we do this at 12:30 Central Time on Tuesdays. We really appreciate you being here and you're getting so much out of it. I mean, have great guests like Laura here is just a wonderful thing. And so I encourage you all to join us every week for this great CCN that we have with such great guests. And again, thank you, Laura.
Great. Thank you guys so much for
So
having me.
much. Thank you.
And thank you to my co-host, Juanita St. Croix. Thank you to our producer, Babs Tierno. And thank you again to everybody else. And we will see you again next week.
Bye, everyone.
Bye.